Hello. So I'm here today because I wanted to talk about how speech pathologists, all right, I'll be a speech pathologist who speaks nice and loud. So how speech pathologists can help with some of the communication and swallowing problems in Huntington's, and what some of the challenges are in trying to do that. And I'm interested to hear from you also today what you see the challenges are, and together thinking about how we might overcome some of those. And I'm very fortunate to work in the Royal Brisbane Hospital Huntington's Clinic in a very collaborative team with our Huntington's nurse Lily, the neurologists, neuropsychologists and neuropsychiatrists, and we've got Dr. Rhys Thomas here today as well. And of course, Lauren and Tressa from Huntington's Queensland. And so together, we jointly try to overcome some of those challenges with communication and swallowing. However, we mostly see people in the clinic only about once a year, and so that in itself is a challenge, trying to help people in a practical way in that context of only once a year. I already can't multitask, so there we are. So specifically, some of the communication challenges that we're talking about are speech, slurred pronunciation, speaking too loud, too quiet, too fast, too slowly, difficulty thinking of words or thinking of names of things or people, processing information that other people are saying, reading and writing, staying on track in conversations, and even the non-verbals. So we know that more than 70% of communication is actually not what we say, it's the facial expression and the gestures, and we know that that's very difficult in Huntington's as well. And so quite often we need to look at assistive communication aids to overcome those challenges. And then of course there's challenges with swallowing food and drink and saliva. So I'll talk a little bit more about these. But I think one of the challenges is that these things change throughout the journey of Huntington's. So in the early stages there might not be many obvious speech and swallowing difficulties. But in the middle stage, when we're seeing more memory and behaviour changes and more movements, that's when we start to see speech and swallow changes. Things like eating too quickly, food spilling, choking, being hungry all the time, and perhaps not being aware of those problems makes it challenging to try and solve some of those problems. And then in the later stage of the journey, when there's more severe movements and people are more dependent, then eating really becomes quite problematic. Swallowing saliva and choking and pneumonia, and even a loss of interest in food. And so the goals for how we the challenges and the goals and how we manage those challenges changes over time. So at the beginning, we really want to be informing you of what might happen and planning and documenting wishes. And in that middle stage, we're really looking at those practical strategies for communication and managing swallow symptoms, with the goal really of maintaining nourishment and hydration and really reducing risk and distress. And in the later stage, we're really just focusing more on quality of life, maintaining dignity and minimising those symptoms. And we need, and that's when we're really looking at things like assistive communication aids and feeding tubes, yes or no. And we try to advance plan for these things. And I think that's one of the challenges, that where we want to be talking at the beginning when we're planning, when we're talking about would you like a feeding tube or not, your swallowing's fine and you don't need a feeding tube, and so it's quite hard to think about those things. But then if your swallow worsens and the decision is needed, it's quite hard to make that decision. And it's hard to communicate that decision. And so advanced planning is a really big challenge that we try to look at in clinic. We still don't feel that we get it right, and that's something that we need to find better ways to address, I think. All right. And a similar challenge is when we're talking about communication, when we start to talk about the strategies you might need, you don't need them yet. And then later when you need them, it's too hard to learn them. And it's a challenge that there's no easy fix. It's about learning new ways of doing things and then practicing those things daily, and perhaps needing another person to remind you. And we all hate being reminded and told how to do things. I hate it when my teenager tells me how I should be using my computer. It's not easy being told what to do and reminded what to do. And we need structure and consistency, and that means consistent carers, people that know you very well, that know those routines. It's a challenge that Huntington's isn't common, and some of the usual treatments that work for other illnesses don't work in Huntington's. And so not all speech pathologists in the community might know about some of those strategies. And it's hard, and it's a challenge if time and energy is being spent on things that don't work. And solutions sound really simple. Some of the solutions sound too simple to fix a complex problem, and so people tend not to use them because it just sounds too easy to be something that might work. So it's actually the very simple things that are the most effective. So we know that to help with clear speech, just talking slower and louder is helpful. And that can be carers asking, can you tell me that again slower? Can you tell me that again louder? Rather than, what? I can't hear that. Asking a question that just has a one-word answer is easier. Do you want to go outside or stay in? Do you want a cup of tea? Yes or no? Finding a quiet place to sit. Let's just go and sit in this quiet corner over here and turn off the TV. For losing train of thought, it could be just reminding someone, you were telling me about such and such, if someone loses their train of thought. Or for remembering words. I can't find my, well, what do you do with it? What do you want to do with it? I want to read. Do you need your glasses? No. Is it your book? Yes. So very, very simple things can actually make the process of communication easier. And then processing information, just using shorter sentences, having less information there to process, talking about things in context. And when communication becomes very difficult, it's very difficult to communicate very important daily needs or interact fully with others or express personality and join in those care decisions and convey fears and concerns. And that's when assistive communication aids are needed. And often what's provided is one of these very fancy high-tech machines, and a lot of the time they're unsuitable. The one at the top you can see there, it needs a lot of fine motor control, and if hands-free options that are like head laser pointers need good head control and to be able to sit very, very still and concentrate for long periods of time. So you can probably see why some of those are less easy to work. And instead what does work is really simple things done well. So we can have a communication book with just pictures or words to point to, frequently used phrases or things that people want to say a lot, or say frequently. It can be a combination of pictures and words, and they're arranged in a book with the most frequently used ones at the front. There can be some alphabet spelling chart to spell out words that aren't in the book or unexpected things. And it's helpful to have photographs of family members or pets or favourite holidays. And these provide opportunities for carers to get to know the person with Huntington's, but also providing opportunities to sit down and reminisce and think about some of the fun times. And it can be a fun activity building these books, gathering the photos together and creating those books. And speech pathologists can help build these very simple tools, but if they're used well and they're tailor-made to the person and they're helped by a speech pathologist and then carers are trained how to use those, they actually are surprisingly effective. But they also need to be used consistently by everyone in the family unit and need to be used daily to be effective. I think it's sometimes a challenge getting NDIS to fund speech therapy time. It's easy to get funding for a $4,000 machine that might not be effective. It's quite hard to get funding for 25 hours of time to train 8 different carers or carers that come and go, or train people over time as needs change. So that's a challenge that we're working on just by trying to inform and educate. And then big challenges with swallowing, I think. So speech pathologists can help educate and train people how to recognise what's actually happening when coughing and choking occurs. So by choking we mean food getting stuck that can actually block the airway. So you can see on that picture there that green food is covering the entire airway, and it doesn't happen often, but it's an emergency situation, and what we need to do about it is to get that food out of the airway very, very fast. And then it's a different thing that happens when food and drink go down and don't entirely block the airway, and we can assist the person to cough. If we can hear their voice, we know that there's some air moving in and out of the airway, so it's not completely blocked, and that can help make people more calm and help the person in that situation. But we need to try to minimise that, because we know that over time, repeatedly, that can cause pneumonia. So we need to identify what the trigger foods are and see if we can change them or the manner of eating. So if it's about eating too quickly, ways, or eating too big a pieces, what are some of the simple things that we can do to still enjoy the foods but eat in a different manner that's going to reduce the risk of those things happening? And here's just some small things. So often the eating rapidly is about people being hungry all the time, so having small frequent meals to reduce hunger, or if someone has no appetite, finding what some of those favourite foods are. If cutlery becomes quite tricky, finger foods, I've seen people do great things with little macaroons that they just pick up and crush in their fingers, or nachos that just get crushed in the fingers and put in the mouth, or finely cut up food. And then speech pathologists can work out which kinds of, sometimes thin, bubbly drinks go down better than thick drinks. So it's not a one-size-fits-all solution with thick fluids. So that's some of the things that we can do to overcome those challenges. And then there's some really simple environmental things that we can do around the person with Huntington's. We know that sitting upright and sitting as still as we can helps that swallow process be safer. So it can be having a special chair or a seatbelt. We know that attention and concentration is a huge factor on reducing that risk of food going down the wrong way. So how can we remove distractions at meal times? Having routines and rituals to help with memory and remembering the safe way to eat and drink. And it helps people to be really calm when eating and drinking. So calmness is induced by sometimes having less discussion and less talking, less loud noises, and maybe fewer people around at mealtime. So these things don't work for everybody, but it's helpful to work out which things work for which people. One of the biggest things is about the rapid big mouthfuls of food, and we know that things like small teaspoons, small plates help with that. Having a straw or a valve top cup that only lets one little sip out at a time helps that. Maybe even only presenting one or two pieces of food at once until it's all gone, and then putting the next one in. So small things that people around the person with Huntington's or the person with Huntington's themselves can do. Something that's not so well known is that one of the biggest things that we can do to reduce the risk of pneumonia is actually about thorough teeth brushing. So more germs get into the lungs from an unbrushed mouth with lots of bacteria in than if food and drink goes down there itself. So it's about helping to thoroughly brush teeth, ideally after every meal, but if that's not achievable, at least twice a day. Electric toothbrushes, even if they're not switched on, are helpful to get right to the back corners. And if making sure to brush teeth and gums and dentures if there's no teeth, because that's where the bacteria accumulate that can really be a very frequent cause of pneumonia. And then I think this next part is probably the biggest challenge. I think a lot of these strategies I just talked about can feel really restrictive for the person with Huntington's, and one of the challenges is to balance out safety with independence. So things that we put in place might restrict a diet or impose rules or feel like a loss of control, and all these things go against the independence of the person. And then if someone has difficulty remembering why those restrictions are there, or it makes them upset having all those restrictions, it can be more difficult. And there's really no easy solution for this apart from just negotiation, reaching some compromises, and again, just that consistency and routine. So this is where it's important to train some of the carers who might be coming in to help about what some of the safe routines might be. And then I think this is what I see as perhaps one of the biggest challenges, is the choice and decision making about having tube feeds, yes or no. So what we try to do is make sure that everyone understands the facts, because not everyone does have a thorough understanding of what tubes are and what they can do. So people generally know physically what they are, a tube going to the stomach, and that they're to provide nourishment and hydration, and more to reduce the effort of meal times. But we have to be really clear, they don't slow down the progression of Huntington's. They might be dislodged with movements, and they require daily care. They can get infected or blocked, and they don't stop food or saliva from going down in the airway. And what this means is that they're not the solution to every problem, and that they're not for everyone. We want to tell people that continuing to eat and drink, we want to help you do this as long as possible, for reasons of enjoying what you're eating and drinking, and for that social connection that comes with the eating and drinking. There is an increased risk of food going down the wrong way in pneumonia, and it can then be quite hard to stay nourished and hydrated. Mealtimes can be really fatiguing and really effortful, and choking can be frightening for the person who's choking and for the person who's there next to them, and it can take a long time to have meals. And so it's again one of these things where we're balancing up two not perfect options. Things that I like to tell people are that you can have a peg tube, and still eat. In fact, we try to do that. And if you make a decision right at the beginning, it's a decision that's not fixed. It can be changed up to a certain point. So we're not tying anyone into a decision at the beginning. But ideally, we do still want to plan and discuss this early. I just said it's a really difficult decision, but we really do want to try to avoid those last-minute crisis decisions and make your wishes known early on. And what we see happening occasionally, when I talk about a crisis decision, I mean, if you fall over and end up in hospital with a fracture, and somebody looks and says, oh, you're not eating very much and you're very skinny, we need to put a tube in, and it hasn't been thought about and discussed and decided. And we really want to try to avoid those situations happening, so somebody doesn't end up with a tube that they didn't want in. And that's one of the most important reasons, I think, for talking about it early. So what we try to do then in clinic is, when you come in, chat to you about, these are the facts, this is what they're for. We want to repeat those discussions over time, because we know from the research and we know from knowing people that no one makes a decision hearing something the first time. It's a really big decision, it's a really hard decision. People need time to think about it and ask lots of questions, so we would try to discuss it so you've got that opportunity to have a think and ask questions. There might be different opinions from different people in the family. There might be somebody when you go into hospital that says you need one and you don't think you do, and then that's very difficult. So what we really would try to do is have a discussion, find out what it is that you want, write it down, and make sure that that plan is given to the GP and it's in hospital records electronically, to try to ensure that what it is that you wish to happen does happen, and that everyone who's involved needs to be aware of that decision to help that to happen. And the health team try to provide support to manage the situation, whichever decision you make, to have a tube or not to have a tube. And then we try and, no one has a crystal ball to say what comes next, but how can we help you manage whatever situation you find yourself in. Okay, I think just to say, really, different choices obviously suit different people, and different people have different reasons for making choices. We know that the research tells us that less than a quarter of people with Huntington's choose to have a tube, so it's certainly not something everybody does. And so there's no real easy answers. And I just wanted to pause here to see, I've talked to you about the things that I think that we can help you with, and that I think some of the challenges are, and I wondered if anyone had any thoughts or questions or queries or concerns about any of those things that I've spoken about just till now.
We've got a bit of a 1 minute warning, and we're going to have you on the panel again.
Yeah?
Yeah. Can we hold those till
Yeah,
then?
okay, so think about your question, hold it there,
Sorry.
and we'll come back to it.
I feel like
Yeah, no, that's it. That's the last thing. I just wanted to say what we try to do is, it's not easy, but we try and put the person with Huntington's at the centre, and different teams from the Huntington's Clinic, people in the community, NDIS therapists, GPs, carers in the home, residential facility staff, Huntington's, Queensland workers, we're all here to try to tackle these tricky challenges together. So thank you.